Hi everyone and welcome to my YouTube channel. My name is 𝐄𝐯𝐞𝐫𝐲𝐭. I'm a cardiac MRI radiographer and today we are going to talk about cardiac MRI at 3 Tesla. In particular, we will discuss about the major issues that you can encounter when scanning the heart of a patient at 3T and how to improve the overall quality of our scan. So most of what we are going to discuss today is based on this piece of paper, namely the CMR guidelines for cardiac MRI protocols. I will leave the link in the description so you can find it pretty easily. So at present, as probably many of you are aware, 1.5 Tesla systems are those used for the majority of the examinations. However, as reported in these guidelines, there is an increasing number of cardiac studies that are being performed at 3T, with advantages and disadvantages that we are going to evaluate today. Let's start by saying that all the images that you're going to see today have been acquired with this scanner, which is also the one you can see here behind me, and this is a 3 Tesla Siemens VIDA scanner, and that's the software of this scanner, the Singo XA30. However, I have to say this is not the only 3 Tesla scanner we use for cardiac imaging in the department where I work. In fact, later on in the presentation, I will try to make a comparison based on my personal experience between scanning the heart of the patient in this Siemens 3 Tesla and doing the same in a Philips 3 Tesla. So we will see who will be crowned king of the vendor. But let's start to evaluate the quality of some images obtained in this one, the 3T Siemens VIDA. So as the CMR guidelines illustrate, balanced steady-state free precession is the method of choice for cine imaging, as it provides high SNR and excellent contrast between the myocardium and the blood pool. However, a major issue exists when this type of sequence is used on a 3 Tesla scanner. In fact, their increased sensitivity to off-resonance effects results in the presence of marked dark banding and flow artifacts. So if we look a little bit in greater detail the images, we can see there are some very clear differences from the 1.5T. However, I would say that overall the image quality is still more than acceptable at this field strength. What generates some concerns is the fact that the overall quality of the cine especially is quite difficult to predict at 3 Tesla. What I mean is that sometimes the number of artifacts can be so pronounced that even scanning a young patient with a normal ECG trace can become pretty challenging. And an example of what I'm referring to is this 3-chamber cine. We can clearly see from the image that the number of dark banding and flow artifacts is so marked that it's almost difficult to assess the viability of the left ventricular outflow tract. Sometimes trying to acquire a cine for a better assessment of the aortic valve can be pretty challenging as well. As you can see, when the valve opens, the flow artifact can be extremely more emphasized at 3T compared to the 1.5, and the situation does not really improve when we try to evaluate the pulmonary valve. So you can clearly see from this example that the RVOT is affected by similar artifacts as those as we saw before. So the question is, how can we reduce this? How can we actually improve the quality of cine imaging at 3 Tesla? Well, there might be a number of tricks that the MR radiographer can adopt to try to minimize some of these problems, especially as regards to the frequency artifacts. So Siemens in this sense is pretty good in giving us some of the hints. Usually the first one provided is to adopt the right table positioning strategy. The aim is to have the heart where the magnetic field is the most homogeneous possible. For cardiac MRI, perhaps local range might represent the most convenient options as regards the table positioning. This strategy is normally used for small examinations regions where a movement of the table is not really necessary. But how does it really work? So local range is based on a examination specific tolerance area and a focus position, which can be chosen by the radiographer by moving this small yellow triangle that you can see here, and that defines the center of this area. Slice groups within the tolerance area are consequently measured without repositioning the scan table. This allows the heart to remain for the entire length of the examination in a position of the ball where the magnetic field is rather homogeneous, and that is done without continuous reshimming of the scanner. After selecting the right table positioning, the scanner may ask the operator to evaluate the initial quality obtained from cine imaging, usually after the acquisition of the 4-chamber long axis. If bending artifacts are too pronounced, a frequency scout can be run to try to improve the quality of the cine. So you can see an example here, several images, so we can go from the beginning. So several images with an identical geometry but different offset frequency will be acquired, and as suggested, we need to locate the best looking image and make a note of the frequency value displayed, which is the one you can see at the bottom of the images. Sometimes a small variation like minus or plus 50 Hz can have a major impact actually on shifting away those detrimental true frequency artifacts that can make difficult the assessment of the anatomy of interest. So once we noted the value, the frequency value desired, we need to change the true delta frequency, which can be found in the subcardiac menu under physio. The value can range from minus 300 Hz to 300 Hz, and it's worth to note that the value you are going to enter would then be applied to all the remaining cines. Therefore, any changes in shifting away the frequency artifacts will also be visible in the other cines you are going subsequently to acquire. Another potential solution that it might worth to try is a manual shimming done by the radiographer focused on that specific cine we want to prescribe. So let's say that we want to acquire a better 4-chamber because the one we just acquired was affected by lots of artifacts. So in this case, what we can try to do is copy image position, as you just seen, of the shim voxel on the 4-chamber we just acquired, and then just try to adjust it according to the anatomy of interest. So you just need to cover that specific portion of the heart that you want to image. So this kind of action alone sometimes is more than sufficient to get rid of most of the artifacts. So now that we have evaluated some of the image artifacts at 3 Tesla and how to cope with them, it's now time to address another crucial factor in cardiac MRI, namely the ECG. So the CMR guidelines say that the ECG gating might be more problematic at 3T compared to 1.5, and they also recommend, in case where the ECG signal is pretty unreliable, to use perhaps the peripheral pulse gating, which might succeed for acquisition that requires a retrospective way of triggering, like for instance in the case of the cines clearly. So I have to say that personally I didn't have this kind of feeling that 3 Tesla is more exposed to this kind of issue, particularly in this scanner. The fact that we can actually use new vector cardiogram gating techniques allow us to reduce a little bit some of the major problems like the magneto-hydrodynamic effect and improve the reliability of the ECG trace. In addition, if we select auto ECG, it will automatically pick up the best ECG trace for us. And as you're seeing right now, this new scanner like the Siemens Vida has also like a biometric technology that will allow you to discriminate how the patient is breathing without the use for an external component like a bellow placed on the patient chest. The third major issue in the association between cardiac imaging and a 3 Tesla magnetic field is the fact that many metallic implants or devices that have been tested and determined to be safe at 1.5T may not be safe at 3 Tesla. That's why when we access the compatibility of a device, it's always crucial to make sure that this latter is categorized as MR safe or at least MR conditional. So to find this type of information, ideally we want to rely to the device ID card. This is a very nice example provided by the FDA regarding what are the type of information and details that you might expect to find in this ID card, in this case for a cochlear implant. So we can see that there is a number of information ranging from when and where the device was implanted to the serial number and so on. You might expect as well to find a statement regarding the compatibility of the implant with the MRI. Normally, if this is not available on the card, you can try to find it on the company website, and there might be some very useful information such as the maximum strength of the magnetic field in which the implant can be introduced, and again the type of coil that must be used, the maximum spatial gradient, the slew rate, and so on. All of this clearly must be accessed prior allowing the patient to enter to the scan room. An additional source of information for radiographer is also the MR safety website designed by Dr. Frank Sherlock. This website contains a list with a remarkable number of implants and information related to the compatibility of these devices at different magnetic field strength. It may come very handy, especially when you want to have an overview of the safety of a specific category of devices. Despite what we said so far, cardiac MRI at 3T is not just concerns and drawbacks, but is also like exploiting the benefit of a 3 Tesla magnetic field, like for instance the fact that we have twice the signal to noise ratio compared to 1.5T, and the possibility to achieve better spatial and temporal resolutions. So in this sense, the late gadolinium enhancement, which is a crucial part of cardiac imaging to evaluate the presence of myocardial scar, can benefit quite a lot from the availability of greater SNR. We are seeing now 3 examples of 𝐊𝐍𝐼 long axis acquired at 3 Tesla, and in this one for instance we can see how well marked is the contrast between the suppressed signal of the myocardium and the rest of the anatomical structure that characterize the heart. In addition, if your center requires you to acquire a dataset of 𝐊𝐍𝐼 dark blood images, be aware that these benefits that we just mentioned can work in the same direction for this, and in fact it works in a very similar way as for the white blood. So the fact that we have a greater number of protons that contribute to the signal increases significantly the quality of the image that we can perceive actually. And you can see here a PSRR views of different dark blood 𝐊𝐍𝐼 long axis and how nicely the myocardial scar can be depicted. And this is subsequently confirmed in the PSRR view of the short axis dark blood 𝐊𝐍𝐼. And this can be applied in a very similar way to the early GAD enhancement as well. If we need to acquire this to exclude the presence of a thrombus, again the availability of a greater level of SNR will enable us to depict a little bit more easily the presence of an abnormality, like in this clinical scenario where there is a thrombus located toward the apical part of the heart. But that's not the only sequence that will benefit from a 3 Tesla magnetic field strength. In fact, it has been demonstrated that real-time imaging can benefit quite a lot from it as well, especially as regards the blood myocardium contrast to noise ratio efficiency. You can see here a very nice real-time sequence acquired in a patient that was struggling in holding his breath. And finally, another part of the cardiac scan that takes advantage from all what we mentioned so far is the first pass contrast enhanced perfusion imaging, which is normally performed on patients with known or suspect coronary artery disease. At present, we know that there is an increasing number of consultants that are actually asking to have the stress perfusion scan to be done on 3 Tesla scanners, and this is due to superior diagnostic performances, especially as regards detecting myocardial ischemia. However, all these advantages sometimes collide with the safety matter. A case in point is the patient with the cardiac implantable electronic device, which at least at the moment cannot really benefit from anything of this, mostly because all these kind of implants are just conditional to the 1.5 magnetic field strength. So overall, I have to say that if a verdict must be made, I should say probably that yeah, there are quite a lot of advantages of scanning cardiac at 3T, but at present steps must be taken to furtherly address concerns like the safety at such of magnetic field strength, and also perhaps new ways to reduce the artifacts that compromise the quality of cine imaging should be experimented. that would be definitely represent a huge improvement. It must be said, nevertheless, that different MR scanners have different technology and features. So as I mentioned at the beginning, I'm going to try now to draw a comparison to understand where, in my opinion, Siemens and Philips scores better respectively. So let's start now to try to analyze the software. And I have to say that, in my opinion, the Siemens software is much more user-friendly, and I like how parameters are categorized and displayed to make very easy for everyone to achieve the desired adjustment. So there are also all these hints that Siemens provide whenever you need to reduce the SAR, that especially at 3T they come very handy. As regards cardiac, the physio section is very intuitive. I really like a lot the way you can switch quite easily from retrospective to prospective gating in case you want to favor a specific part of the cardiac cycle. Therefore, personally, I would say for now Siemens 1 and Philips 0. A different story, however, might be told as regards the image quality. Do you remember this image, the one that I showed some moments ago to illustrate the benefits of acquiring the early guard announcement at 3T? Well, it did not come so nicely at the first attempt. I have to say that with oversized patients, Siemens requires an extra level of attention toward parameters like the field of view or the phase oversampling. And yeah, you definitely need that if you want to avoid wrap within the image, like what happened in this 2-chamber view early guard and in this 4-chamber view early guard. Don't get me wrong, in Philips you will need definitely to make sure that you have a good amount of oversampling as well to avoid this kind of artifacts. However, under the same condition of field of view and oversampling, cardiac images in Philips, in my opinion, have a lower probability to be affected by wrap within the image compared to Siemens. So in this perspective, I had to say that my point in this specific field would go to Philips. Also, remaining in the evaluation of the image quality, I have to say that this mix from bending and flow artifacts deriving from the acquisition of balanced steady state free precession at 3T is much less evident in Philips, and that's definitely another point that must be given to Philips. In fact, it's very rare that I had to reposition the shim voxel or run a frequency scout to try to shift away the artifacts in the 3 Tesla Philips scanner. Sadly, as you can see again from these images that I showed before, it's not very uncommon in Siemens instead, and that's why it's always better to be fully equipped and be ready to cope with this kind of issues. Have a frequency scout in all the cardiac protocols in the cockpit and adjust the shim voxel according to the axis that you want to acquire to prevent this kind of artifacts from compromising the quality of the entire scan. So we now have seen how different scanners cope with oversized patient or artifact due to the high magnetic field, but we haven't seen yet what they offer in terms of solution to deal with patient with complex ECG traces like this one. For those of you that have some experience in cardiac MRI, you probably may have struggled at least once in a lifetime with a patient who had ectopics or a patient with atrial fibrillation. So in this sense, the possibility to have a very nice late guard announcement like this one, for instance, in my opinion is simply pioneering. There is this specific software that is provided by Siemens that will allow you to acquire all the data sets of late guard announcement with motion correction, which is also called MOCO. And the result is simply surprising in my opinion, especially considering the fact that all the images you are seeing at the moment have been acquired in a patient with atrial fibrillation, which normally significantly deteriorates the quality of the overall scan. So definitely thanks Siemens for inventing this or providing this to the radiographers. So to recapitulate, we reached a point in which both Siemens and Philips have 2 points each. So now is the time to address the last field, which is education and training. And how can we not mention the lovely PepConnect? So PepConnect is this kind of online portal developed by Siemens where healthcare professionals can enhance their knowledge by attending a huge variety of courses. Most of these, including cardiac MRI courses, have free access. And I have to say that what I really like regarding this type of platform is the fact that despite there are a lot of courses that have been designed to train Siemens users on different Siemens platforms, there are also several courses that have been designed to train everyone, like this involving MR physics. So regardless the vendor you're using, you can actually gain a lot of skills from this kind of platform, which is highly beneficial for everyone. And so considering this, I have to say that personally, with a score of 3 points out of 5, Siemens today brings at home my personal trophy as a favorite MRI vendor, especially as regards cardiac. However, if you have any experience of cardiac MRI with Philips scanner with brand new technologies and perhaps new software as well, please feel free to just share your comments. And as well, if you have experience with different vendors like GE and Canon, which sadly I'm not very competent, especially as regards cardiac, please feel free to leave your feedback in here. I believe this is a very nice way to increase the overall knowledge of the entire MRI community, but also to get a little bit more involved in this field as cardiac MRI radiographers. Also, if you liked this video, which was my very first one with this kind of setting, please consider to subscribe to my YouTube channel. The plan is to develop some new material regarding tips and tricks, not only in cardiac MRI but also some related topics. So I hope we can keep in touch for some interesting new MRI material. But in the meantime, I'll see you around.